Good afternoon, good evening, everyone, and thanks for joining us here at the Advent Health Orlando webinar studio for the latest of our webinars on colorectal surgery. We're looking forward to an evening of discussion on a topic that I think has become very important for people over the last 6 to 12 months, which is namely issues of smoke in surgery, particularly laparoscopic and transanal surgery. My name is John Monson. I'm the Executive Medical Director of the Digestive Health and Surgery Institute in Advent Health Orlando and Central Florida. I'm joined here today by two of my faculty colleagues. On my left is Matt Albert, known to many people in colorectal surgery from his work on TAMIS and technology development. And Matt will be talking to us and showing us some videos in due course on specific issues in relation to transanal work. Before that, however, I'm delighted to introduce on my right Dr. Mark Soliman, who is the Program Medical Director and Division Chief of Colorectal Surgery here at Advent Health Orlando. And he has spent some time over the last few months telling the social media world about aspects of smoke in viral transmission and such matters in laparoscopic and robotic surgery. So we're looking forward to an initial presentation on the whole picture of that type of issue in relation to colorectal surgery as it applies during the COVID-19 pandemic. So without further ado, I want to hand over to Mark. But just before doing that, I want to say to you, there will be a facility for those of you who are registered, of course, to ask questions. There'll be a Q&A session. You get to type this in on the Q&A section on your login. We'll be able to see these later, in fact, during the presentations and later, and we will come back to them. We have a good platform to do this for this session today, and I should acknowledge, just for the record, that this Advent Health Colorectal Symposium today is supported very generously by Boehringer, who have been very helpful in bringing this together tonight. So over to Mark for his presentation.
Great, thank you, John, for the setup and for the introduction, and also thank you for the invitation to do this as well. You know, surgical smoke evacuation in COVID-19 is an actually incredibly controversial topic, and controversial for many reasons. And the reasons being is that as much as we know about COVID-19, there's a lot of things we don't know about COVID-19 and don't really know even about smoke production in general. So what I want to do today is kind of break this discussion down into the background of what we're talking about tonight, the dilemma that tonight's discussion brings up, go into the, in air quotes, the solution to what surgical smoke production in COVID-19, what potential solutions and mitigating factors that we have, and then close this off by talking about the potential relevance and how this actually, on a granular level, impacts us in the day-to-day in the operating room. Talking about the background, there are some knowns within this space. What we know is that COVID-19, or it's SARS-CoV-2, which is coronavirus disease 2019, which is where it got the nomenclature of COVID-19, was, as we know, diagnosed in Wuhan at the latter part of 2019, the beginning part of 2020. And it's an RNA virus. And this RNA virus has a whole host and a whole family of viruses. And the coronavirus family encompasses many, many, many different viruses. Some of them are very benign, like the common cold. Some of them can be a little bit more virulent, stuff like MERS-CoV or SARS-CoV. And this great variance in virulence of coronavirus has a lot to do with what the viral shell looks like, what the virion size looks like, and all these kind of particulate matters that occur and are relevant to the RNA virus. This RNA virus, each of the particles, as we'll call them, these virions, vary in size. And it's important to understand what the virion size range is, because it plays into the different filters and the different ways in which we try to prevent and protect ourselves against it. So we know that the RNA virion size of SARS-CoV-2 or COVID-19 ranges from 0.06 microns to 0.14 microns in size. So keep those numbers in mind, because it's going to play throughout the entire discussion today in terms of selection of filters and whatnot. What we also know about COVID-19 is that it has been isolated in the epithelium of the respiratory tract, in the GI tract, in the peritoneum, in the stool, and in many other sites in COVID infected patients. In fact, a study that was done in the latter part, the earlier part of March 2020 showed that there was prolonged fecal shedding of COVID-19 in patients that, even though they completely were free of virus when it came to their RNA testing and also into their PCR testing and the nasal swabs, they still have prolonged shedding of virus for up to 30 days after clearing the virus. So why does this who cares, right? What's the big deal about this? Well, the issue is we have a lot of unknowns. The unknowns in this is, if we were, say, to, for example, cauterize tissue of an infected patient, does this cause viral aerosolization? Now, we know in HPV or herpes, human papillomavirus, HIV, or even HSV, herpes simplex virus, anytime you have an actively infected portion of tissue that you actually cauterize, what you end up doing is you actually do aerosolize that virus to the air. And that's why we that do a lot of anal condyloma surgery, we always wear N95 masks. We always want to make sure that we have the Stackhouse suction present to protect the OR staff in the room and to keep people safe. That's the whole idea behind it. So if you were to extrapolate that same data that was done actually in the early 80s, looking at viral aerosolization of HPV, HIV, HCV, and all these other viruses, if you were to extrapolate that onto now COVID-19, this current pandemic we're dealing with, is there a legitimate concern for viral aerosolization of COVID-19? The truth is, we don't know the answer to that. We really don't. Until today, until October 2020, we're nearly a year into this pandemic. We actually still don't know if this is an actual legitimate concern. But the challenge here is, if we don't react to this well, if we don't protect the staff, if we don't protect the patient, if we don't protect everyone in the room, there could be catastrophic complications that occur if patients are infected and staff are not protected during these operations. And that's why you'll know every single surgical society has put out some sort of statement emphatically requesting that the people that are in these rooms, whether it's during a colonoscopy, during an open operation, or during a laparoscopic or robotic operation, that they wear full PPE to ensure that they are filtering out potentially aerosolized virus. But this still remains, until this recording today, an unknown in COVID-19. With that said, what is the solution to this? What is the solution to this theoretical viral aerosolization and how to mitigate these issues? And that's what we're going to talk about tonight. So there's two big, basically, branches that we want to talk about. We want to talk about, first, prevention of aerosolization, period. And the second one is prevention of transmission. So let's talk first about prevention of aerosolization. When it comes to prevention of aerosolization, what we're talking about is doing whatever we can to not even have the threat of cauterizing tissue, to not even have the threat of cauterizing virus, to not even approach this discussion of, are we going to cauterize tissue that will cause it to aerosolize? And that's, we're talking about prevention of aerosolization. So surgical sites all talked about, just don't operate. Don't operate on COVID-19 patients. Make sure you do pre-op testing to ensure that they are, in fact, COVID negative. And in the fact that they are COVID negative, how to mitigate, how to can keep potential viral aerosolization contained within a closed circuit of the abdomen. So that's, again, talking about prevention of aerosolization. We'll talk a little bit more about closed circuits and all that in just a minute. The other step in prevention of aerosolization is to minimize, to the greatest extent possible, the amount of cauterization that is occurring during an operation. And this is why a lot of things we're talking about, or at least we talked earlier on in the pandemic and early on in webinars, was to use, instead of cautery, use no cautery. We would, instead of cauterizing tissue or cauterizing blood vessels, we would staple the blood vessels. We would talk about doing the least amount of cautery necessary to get an operation done in the safest and most prudent manner possible. That is all theoretical. That is all about prevention of aerosolization, period. Let's assume for a moment that we're in a situation in which aerosolization is a fact of life. There is no way to get around it. We are stuck in an operating room, and we're just going to accept the fact that no matter what we do, virus will be aerosolized. Pardon me. Well, this is where we talk about two main things: filtration and masks. So how do we filter it out if we're going to produce the virus or produce viral particles? And how are we going to mask against it? And this discussion is extremely important. Extremely important in TAMIS, extremely important in TATME, extremely important in open surgery, endoscopic surgery, laparoscopic surgery, robotic surgery, whatever the operations are. This topic of prevention of transmission is critically important. And what we're going to talk about in just a minute are different ways to contain that virus within a confined space. And that's one of the best ways to afford filtration. So let me go to the next slide here. And I'll say that at the time of this recording, that there are two different insufflation devices out on the market. Insufflation, not filtration. Insufflation devices that actually have filters built in that will filter out SARS-CoV-2 because they go down to that particulate matter size. Now let me talk about this just for a second. What we're talking about here specifically is minimally invasive surgery. In an open operation, you are going to have potential viral aerosolization, in which case you have to try to capture that smoke, prevent it, or capture it and filter it off as quickly as possible. And this is why we are talk about using Stackhouse suction that is filtered at the back end with a Neptune suction with ULPA and HEPA filters that go down below the particulate matter size of SARS-CoV-2. But we're talking here specifically about minimally invasive surgery, which Dr. Albert's going to also talk about. And in this, what we're trying to do is we're trying to maintain a closed circuit. And this is why a lot of us in the minimally invasive space will emphatically talk about you must maintain a closed loop, a closed circuit. Now what that means is there's a closed environment. We're doing a colectomy. We're doing a right colectomy. We're doing a low anterior section, whatever it is. We are operating in a confined, closed space in which there are ports shooting in CO2, and there's sometimes manners in which some of that CO2 gas might escape. Now, let me first take a moment to explain what and how insufflator devices work. In the most traditional sense, CO2 enters through a trocar. The circuit that is instilling the CO2 into the abdomen will inject CO2 for 3 seconds, pause for 1 second, check to see what the intra-abdominal pressure is, and it checks it against your set point. So if you set it for 12 millimeters of mercury, set it for 15 millimeters of mercury, or whatever it is, it'll say if you have exceeded, or rather if you are below your threshold, let's say you set it to 15, but yet you're at 10, then what's going to happen? it's going to actually instill more CO2 gas to get it back up to that 15 millimeters of mercury set point that you set it back on the device. And if it knows that you are actually, instead of being at 15, you're at 16, the intra-abdominal pressure it's higher than the set point, it won't do anything. It won't inject or instill any more CO2 gas during that specific cycle. 3 seconds on, 1 second off. 3 seconds on, 1 second off. That's a traditional insufflation device. More advanced technologies exist that contain both insufflation and filtration. And some of those are created by companies called ConMed and one called Stryker that have everything built into the system. And there are challenges, though, with each of these that I want to talk about. ConMed has 2 different devices on the market. And the reason that ConMed's a great device is that this big device that you see at the very end there, that larger filter, is the filtration device that it will inject CO2 in the abdomen, it will sample the intra-abdominal pressure, and then it will filter and suction off any of the gases in the abdomen, put it through this filter, and then once it filters out the air, it then exhausts out the rear of the insufflation device in the room, or the CO2 device in the room. So you can imagine that if the CO2 filter that you have on the device is larger than that of COVID-19, larger than 0.14 microns, then theoretically what could happen is, as virus is being filtered back into the circuit, it gets concentrated within the filter and then expelled through the rear of the exhaust of the CO2 device, concentrating and pushing aerosolized virus throughout the room, which could theoretically be a catastrophe. And so that's why it's critically important to pick the insufflation or filtration devices that are smaller than the 0.06 to 0.14 micron sizes that COVID-19 has been documented to live. ConMed has one of those devices that is an all-inclusive circuit that injects CO2, it samples, and it filters off. But there are 2 different devices that they have. They have the ASM evac and the SEM evac. The one on the left here is the ASM evac. This is the one that all of us have. The problem with this one is it is not a closed circuit. It is not a closed circuit. CO2 gas can easily escape through the proprietary trocars that they have. So it's a wide open, valveless trocar. If the patient coughs, if you push on the abdomen, potential aerosolized virus can eject through that larger port, causing a potential issue. And so that's why ConMed has, and most of the societies have said, don't use the ASM evac, use the SEM evac, which is the second one there on the right, which affords a completely closed circuit. Both of them are sealed, valveless or valved trocars rather. It goes on the traditional valves that we're normally using, and it allows you to maintain a closed circuit the entire time. And again, maintaining a filter system to that less than that of SARS-CoV-2. The other system that is an entirely encompassed and closed circuit is the Stryker system, which has a series of charcoal filters, HEPA filters, ULPA filters, and many PVC filters, many other filters that allow the particulate filter to go down to less than that, again, of COVID-19. And that's critical to know, the filter size, so you can ensure safety, again, theoretical safety of those that are in the room and those that are working with you. What I've just discussed are 2 insufflation devices, not filters. There's a difference, because we can certainly instill CO2 with the traditional CO2 device, but there are other items on the market that Matt's going to talk about tonight that talk about how to filter out, not necessarily talking about the all-inclusive insufflation technology. That's the first thing. This is the filtration side or insufflation side, but they're also the filtration side for the mask part of the discussion. There are 2 different schools of thought here. If we can't contain the virus theoretically intra-abdominally, we then got to make sure that we're protecting, giving an additional layer of protection to the staff for potential leaks in the trocars leaks in the transanal extraction sites, for example, leaks in the trocar sites or what have you. We're just accepting the fact that there's going to be potential viral seepage, if that's a theoretical term here, potential viral seepage of the aerosolized virus, and that's why there's a strong advocacy for wearing N95 masks during these colorectal operations. Now, I'll make mention of this, that there are standards by which we live in the N95 world. N95 is actually, what it means is it's 95% efficacious in filtering out viral particles to that of 0.1 micron. Note, the viral particle size goes from 0.06 to 0.14. So the N95 mask is also in and of itself an imperfect barrier between us and COVID-19, but it's the gold standard. This is what we have. This is what we're using. And so even as imperfect that is, this is what we use in the operating room to give us additional layers of protection. So additional layers, surgical mask, N95 mask, filtration, suction, prevention, all these other things hopefully allow kind of a cumulative effect of keeping us all essentially risk-free. Now, I gave this case, I made this discussion, we talked about basic virology, we talked about all these things, but who cares? What's the relevance? And actually, I was just looking on PubMed last night. There still have been, thankfully, 0 reported cases of COVID-19 being transmitted to staff in a viral, aerosolized manner to make us even more concerned about this actually being a potential issue. So what does this mean? We still don't know. There hasn't been a documented case, but there still hasn't been documentation of whether or not COVID-19 is aerosolized or not. So the challenge with all this is there's a lot of speculation. There are still a lot of unknowns, even though we're basically a year into this pandemic. So while we are speculating, while we are at this point and trying to figure out whether this is an issue, even though there are still 0 documented cases, we still have a duty to protect ourselves, our staff, our patients, and everyone else in and around the operating room by filtering the CO2, by prevention of aerosolization, by doing all those things that we talked about today. So even though there's a lot of speculation here, I hope that in a week and a month and in 2 days and a year, there are studies to show that there is no viral aerosolization and that everything I just told you is wrong. And I truly hope that that's the case. But that being said, there is logical information out there. There is legitimate concerns. And while we're at the speculative perspective here, we might as well, again, speculate right and do that which is prudent so that we can protect ourselves and protect our patients. So to that, I thank you for the podium. I turn it over to Dr. Albert.
So thank you, Mark.
Sure.
That was a great presentation on the basics and the science behind this. I think it's continues to pose a lot of thought for everybody involved in surgery and colorectal surgery, and particularly in transanal surgery. So our next speaker is Matt Albert, and it gives me great personal pleasure to invite Matt to speak here tonight. Matt is the longest serving member of the Advent Health Colorectal Group, was the founder of the ACGME Fellowship Program, and one of the co-inventors of the TAMIS system. He is known internationally as a speaker on the subjects of technology development and various aspects of minimally invasive surgery, and as I say, particularly TAMIS surgery originally, but more recently, of course, the introduction of transanal TME, TAT-TME. So he's an important member of our faculty here in Orlando and is going to show us some of his experience in this space. If I hand him over the remote control. Yes, I know. Thank you, Matt.
All right, and now I say, and Chief Operating Officer. I just operate.
Exactly.
Okay, thank you very much for the introduction, and hopefully I'm going to take you on a little tour of really the evolution and history of what we personally dealt with and how it applies now with the current pandemic. I have to thank Eleanor again and the team from Boehringer Laboratories. They really stimulated this by trying to find us some cost-effective, efficient ways to suction extra smoke. I work with the current companies, and it's Transanal minimally invasive, and its role in 2009. It's not lost that colorectal surgery, specifically transanal surgery, was really the first field to document in the quality of the surgery makes a huge impact on the outcomes, on the patient outcomes, and specifically that TEM was found to have significant improvement in patient outcomes over local recurrence compared to transanal surgery. And there was a simple overall reason for this, is because you could do the operation better. And the system that was designed for this, the TEM platform, it was one part improved and enhanced visualization, but I think the key components to transanal surgery in endoluminal surgery in this format have been really insufflation and visualization. It's the access that we needed first to provide better access, and with improved access, and then a distended rectum that's well lit, and then the ability to operate with a clear visual field. And so the major components of this that I think, other than the visualization, that were most important was the insufflation and smoke evacuation. And so here's an actual beginning of the first case that we've done with this. We had the access port once we knew that we could insufflate and maintain a seal, but it immediately became apparent that smoke and maintaining a clear visual field and maintaining an insufflated rectum were the key obstacles to this. There was no question from TAMIS either not being able to insufflate, either from obesity, and the fact what we quickly realized is that when this initial insufflator was made to do TEM, it was very well designed and in fact better designed because it was specifically designed for insufflation in the rectum. And at the current time, and we were doing this, that insufflators were frankly developed for insufflating the abdomen, developed for insufflating the chest. And those were the two major cavities, but insufflating the rectum is a completely different component. And if you can't insufflate the rectum, you can't see, frankly. With TATME, we developed even more challenges with this. And so I didn't give myself this moniker. I don't like Star Wars. I actually sometimes can't even figure it out. But in fact, the single biggest thing that as we embarked on this, and I was working with many reps from companies, was that we would get called on a daily basis, multiple times, emailed, texted, we were getting questions about insufflation, the most basic thing. How do you keep these rectums open so that we can do the operation? And we always developed guidance and panels for them. And in fact, it was Rob Ireland who just said, we're like the TAMIS of Yoda over here. We always, this was known clearly through TEM surgery, that having a completely paralyzed patient, so there was no diaphragmatic interference at all, was critical, important. Always check that. Simple things, you got to close your stopcocks and valves, make sure you're not leaking air at other places, make sure the seal cap is closed. We realized quickly we could increase insufflation and push the maximum to insufflators, sometimes going over to 20, sometimes there were bariatric insufflators that we could go up to 25 and even higher. And if we could dismantle the insufflators in some instances, we even would have tried to make sure, because this was the most critical thing. And when, in addition, you increase Trendelenburg, perhaps getting some of the weight and gravity off the pelvic organs will allow a little bit expansion as well. And so we were always giving guidance on how to better insufflate the abdomen with TAMIS and conventional insufflators. Let's make a little break here. And the other thing is you have to be patient. You know, again, it's not an abdomen, this big, dome that fills up fairly evenly. The organs get pushed around, whereas I'm sure with the colon, there's segmentation involved, that it gets up one area. Everyone's done a colonoscopy where, in fact, you get through an area, it's not blown up, and you pop through, and as soon as you get through, the rest of the colon is massively insufflated. We did this without really any evidence of barotrauma ever with this, but again, we were slowly taking a much greater look at the capabilities and what these insufflators could do. You see, early on, TAMIS case, T1 cancer, especially working close by. And so as we quickly evaluated what instruments we could use for these, that some of these instruments even have some suction regulation off them, but there was always a balance. If you suck too much, then you quickly lose insufflation and pneumorectum. You don't suck enough and you have an impaired field with smoke. And again, the critical component of transanal surgery that allows us to have improved outcomes is that you can see it better and therefore technically do it better than conventional open surgery. I think even that in some instances, an impaired visual field can even lead to complications that could have been avoided. A peritoneal entry there where I'm sure that if I could see that better and didn't have the big burst of smoke and wasn't impatient, that we could have easily avoided that. So as we embarked on designing this platform, this is the gel point path. Most of you know that we helped create this here at Advent Health in 2009. It was helped develop at our Nicholson Center here alongside with Applied Medical. And part of the most critical thing for me, and I think I'd say for the company, is reducing the barriers for surgeons to do this, especially knowing that with TEM and the system before us, there were significant barriers to entry, cost and training being the main things. And so we knew that there was some barrier being the cost of these disposable ports, but I didn't want there to be huge barriers and variations in how people could insufflate the rectum and how they could perform the surgery. We thought about this constantly. And so this was designed with two obvious stopcocks and ports on it. It was designed, one, to have insufflation on it, and one to continuously perform smoke evac. Pre-COVID-19, into the room, no doubt, no problem with that stopcock, or you could put it in to some tubing. Now, TATME really exposed all of our problems with insufflation. And because now we had this very small volume space where we were closing the rectum with a purse string and creating a high pressure, small volume space, of which, as Mark described, the insufflator and how it works, that it's very easy to understand how come every 3 seconds or so, there's a big pause and the rectum beats towards you. You see the problem with smoke as well, and especially in TATME, balancing between smoke and insufflation was critical. But these videos were from 2012 or so, and I knew at that time, before we embarked on training surgeons around the world to do this, there was no way I could convince surgeons to do this on a moving rectum, nor was I going to ask them to do this, to expose this. And the other thing is that insufflation serves really two roles in transanal surgery. That one, exposure. It shows us with adequate pneumorectum, we have a great visual field and exposes things. But more importantly, it facilitates dissection. And it does that because it produces tension on the wall of the rectum. That tension alone augments the natural tension that you have with your instrument. And so with a taut rectum, it's very easy to perform a dissection. With an untaught rectum, you have to create all the dissection space there. And so in the middle of this, probably, I don't know dates, 2015 or so, this was the single biggest improvement that truly changed many surgeons and how we were doing transanal surgery. That this is the first time that we used the air seal from SurgiQuest. And Mark went through this. It had a remarkable ability to improve the insufflation that we had, while at the same time, because of its design, able to produce smoke. And you just saw this ability, enhanced visualization like never before. It helps. Just like some patients have good planes in their abdomen, some planes are really good in the rectum. This one's a beautiful submuscular plane. but it's just the ability to maintain visualization with minimal smokes that make all the difference in the world with this surgery. 99% of the hassles of transanal surgery come from issues with pneumorectum and poor visualization. And then even more so with TATME. I showed you before, but then we started really mixing things up and doing synchronous surgery, and now trying to insufflate the rectum from below while simultaneously asked to do the same from above as these planes were joined. But in fact, this was the essence of why, again, made TATME so spectacular for many surgeons early on, because much of the same rationale that we said, you have better exposure to this, you have better access to this, we can see this perfectly, and look at the view our insufflators and cameras now provide for us, that this is why many thought this and felt this to be the Holy Grail. Again, this was a case doing synchronous surgery with Dr. Norbert Garcia here. That again, we started realizing some of the challenges of it in this, that we often had to turn down the insufflator from above and put these at different, even though they were competing, that we had to change the pressure and amounts they were giving in. But when it worked out perfectly, you saw minimal smoke surgery, perfect insufflation, and really fantastic, technically precise surgery. This was another one of the instruments that we designed along the way. This was a monopolar probe from Applied that simultaneously allowed suction of smoke from the top of the device. And so that helped keep the field clean. But it's not all roses. TATME for suffering some other problems. One of the alarming things was, for the first time in years and years, maybe decades of laparoscopy, and other than laparoscopic hepatectomy and where major hepatic veins were exposed, where we began to see CO2 embolisms. And it's this causal relationship is certainly not perfectly elucidated, but in publication of 25 cases that we did, it seems intuitive that for the first time ever, we're blasting air at very high pressures, at ridiculously high volumes, in very small high pressure spaces, and in conjunction with a pelvic blood vessel, that it not surprising that we saw these. And in fact, this is a redo operation. And during this, you'll encounter tangential vein injury and bleeding. And in fact, if you look closely, you'll also even see air bubbles coming from within that. So the carbon dioxide, which we insufflate when placed in the wrong system, can even kill people. Another huge important component to transanal surgery. Might as well give you an important tip. If this happens to you ever, immediate drop in end-tidal CO2, you stop insufflation, Trendelenburg, and most of the things that people know what to do with. But this really set off a huge development and evolution of insufflators. And suddenly everyone realized that this was a big component of colorectal surgery, and that we needed to bring these insufflators into the 21st century and begin designing them specifically for both insufflation and maximal smoke evacuation. This is, again, I'll say specifically for Boehringer, but I do work with Stryker and some of the other companies. I work critically side by side to help develop the TAMIS mode on the Stryker insufflator. The way these is done is simply by augmenting and changing the algorithms with which Mark described, how long you insufflate and how long you pause, while maintaining safety and pressures as the most important thing. Now, and we also saw development of multiple other insufflators, Storz, Olympus. Every single company began immediately augmenting and changing the way their insufflators worked. And that was the newer one from Lexion is now. So everybody sees the need to have some improvements. While at the same time these things were great, that insufflator overhaul in your operative room is a big deal. These are expensive. These fancy insufflators were even more expensive. And again, I felt strongly that these were barriers to entry to do really fantastic transanal surgery. So this evolved very early on with TAMIS. This is a friend, Tony Miles, not the original Miles. He's a little bit younger, but myself. who found that probably very easily we could augment the traditional insufflators. And so Applied, again, took this upon themselves, and we developed what's called the insufflation stabilization bag. As Mark described, that continuous insufflation into the rectum for 3 seconds is met by a pause. And during that pause, because it's a much lower volume, in the abdomen, you don't notice this pause, but in the rectum, this pause responds by collapse of the rectum, a transient collapse or bellow of the rectum. And so this very simple bag was designed. Admittedly, it's provided free in the kit that this comes with. And you see that the gas flow into the ESB is very high flow. However, when that system takes the bags merely acts as a reservoir to stabilize the rectum. As it pauses, there's a passive flow of CO2 into the rectum to briefly augment it. And so I'll be happy to say that through this, that anything that insufflate a rectum or evacuate smoke from it, I've tried. And so this was a TATME proof of concept. So this was in combination with this ISB. I think this made us feel immediately better that we didn't necessarily need one of the air seals. We don't have the capacity necessarily for every surgeon in the world to operate with the Cadillac of insufflators. You can see though still with this ISB that as we enter the abdomen, if you look into the belly, it's like a washing machine, you know, that this change in pressure that generates. And again, there's things that we still need to learn and overcome from this. As Mark alluded to, one more little hiccup with all of this. And during the COVID-19 pandemic, as we begin looking and returning to surgery, patients that had cancers were taken care of. So naturally, there were TAMIS cases that were being done. They were some of the earliest cases that I was doing. And the oral fecal transmission is really interesting. You know, just briefly, the amount of volumes and studies and published work on this is quite phenomenal. But it's very, there is very dominant symptoms in the gastrointestinal tract. And as Mark said, that's shedding, viral shedding in the stool. Live virus has been detected repeatedly. There seems to be a high rate of PCR positive persistence. And actually the duration of it, given the way most of us triage patients going into surgery, you can say that easily someone had many patients who were COVID positive that were no longer COVID positive, who still very well could theoretically transmit in the stool. At the same time, I don't like a face full of transanal gas. It's not very pleasant. And so this is one of the newer technologies that we've looked at to help facilitate our reduction of gas and maintaining pneumorectum. And so this is a device from Boehringer Labs. If you don't know them, they actually specialize in suction regulation devices, from things in cardiac surgery to the nasogastric canisters on your floor to many anesthesia, suction regulation sets. And this is the most simple, basic of them all. The fact is, this gives smoke clearing ability to any insufflator. And so I don't mind bringing up and demonstrating some of the features of these other insufflators, because Boehringer is not an insufflator company. They're a suction regulation company. So most important, this can augment any insufflator, even some of the best insufflators. There's limitations and you can augment this. It can attach to anyone. It's a really fantastically easy setup. The valves for our trocar are set up to manage this. They attach to totally conventional suction source and filters. So in our operating rooms, we use a Neptune device. It allows the highest filtration of the smallest particles, and it connects to this very easily. You know, in addition to the smoke clearance for visualization, we all know that smoke is extremely toxic, full of carcinogens, and more than 5 states now have put forth regulation to minimize smoke in the operating room. Many know how important I feel about my lungs. And lastly, it's got a sensing line and pressure valve as well. And so at the same time, this is looking and suctioning smoke. This senses pressure in well to not completely collapse all your pneumorectum. So this is how we set it up. The other component of this has an adjustable dial. The one thing is that I've noticed is that everybody's, transanal case is different. Insufflation is always different. In one case, it's fantastic. In another patient, it's challenging. So all these little tips and tricks we've used. So this is a setup. We did this a couple weeks ago. So this includes the access is the gel point path. We use the Stryker PneumoClear system in TAMIS mode at 18 millimeters. We use the ISB bag. If you look on top of the patient, you can see, and I know there's a jumbled thing of cords, but it's because the camera cord and insufflation cord is all up there. But you can see the tubing used for the ISB, the Epix probe not needed. We have the Visimax connected to the port on the bottom there, and then the other end of it's connected to the Neptune, which you see right there in the left upper quadrant. And so here's the case, which I think is important to see in action. It's a 79-year-old, actually very active guy, tennis player, developed excessive mucus and discharge, had a big villus lesion posteriorly at the dentate line, extending about 6 centimeters, 1/3 the circumference. Pathology actually said adenocarcinoma. MRI was T1, T2 with no lymphadenopathy, but given the entire case and MDT discussion, and the fact that it was clinically benign, that we pursued transanal surgery. And so this is the case. You just saw the setup of it, and I'll talk you through it. I think especially very distal lesions tend to be very difficult. John is an expert in transanal surgery with the TAMIS system. There was always reports of some challenges with a very low lesion, but in fact, you can hub the instrument there quite nicely and cause a seal. With these very low-lying ones, we cut the proctotomy first with a regular retractor and then put in the device. And so the distal margin of these, I think, is very critical, and the distal dissection, because when you're below the mesorectum with this, the anatomy is very challenging, from the endopelvic fascia as it fuses to form the layers of the intercircular muscle and the outer longitudinal muscle, or the ability to get too deep into the mesorectum quickly. So being at this level, very close, that the tendency is for the smoke to come pouring back into your face. And the ability to do this at this area with very good precision and clarity. And this is actually Alexandra, our fellow doing this case. This is the first TAMIS case she actually did with me. And so I think it highlights the ability to do this quite nicely, easily teachable and trainable, and doing a very precise dissection. As a tumor this low, it's when I think if you do too big of resection, if you did need further surgery or treatment, it certainly could change your management. So again, precise dissection, I was amazed the entire time. I regulated the Visimax one time. It's interesting, as we went around and showed our videos and taught these TAMIS courses, everybody said, how do you keep your field so clean of smoke? And I said, okay, well, one, there is video editing. There is such a thing. But on the other hand, I think you can consistently see how I do it is because I obsess about it, because I use every single device I need to get rid of smoke while maintaining pneumorectum. You can see even in the setting of a bleeding where you need to maintain a clear field, you can see now when I'm really cooking it, yeah, you'll get a burst of smoke, but how rapidly it clears and you can keep and maintain a field. And that makes a huge difference between sitting there and struggling for 10 minutes trying to find a bleed in there. And so I found it very helpful. And the last thing about this is, again, maintaining a closed system and everything else. There's really two components at times when potential for aerosolization. One is removing the polyp. The cap has to come off. The secondly is at the completion of the procedure. And so in both of these cases I did with it, I recommend you shut the insufflator off while maintaining the suction. I can't imagine it can remove every single bit of air. However, it can certainly remove the bulk of it. So when you remove the access pad, the cap, that the rectum is completely desufflated. So in conclusion, transanal surgery, I think, other than access devices, which we've solved the problem, that still requires a critical component is good insufflation and smoke evacuation to maximize exposure. I think this will enable you good surgery, good outcomes, and minimize complications. Two, the COVID-19 pandemic has really placed some additional concerns of smoke evacuation. I no longer release both stopcocks into the room. I think it's important to keep a closed system. There is an easy way with this to evacuate smoke and put your staff at minimal risk. And I think that, yes, we have dynamite fancy insufflators, but again, trying to reduce disparity across the world. That was one of the fantastic things about TAMIS, that it dropped barriers, allowed everyone to do transanal surgery. Part of that is having cost-effective alternatives, suction separate insufflators, but sometimes suction devices, regulators like this that can make the difference of providing safe and effective surgery and withdrawal of smoke. Thank you.
Thank you, Matt. A real tour de force there on some aspects of transanal surgery and some of the challenges that have faced us for many years. As Matt mentioned, I've been involved in TAMS, or transanal endoscopic microsurgery, for 30 years. And I think one thing that everybody who's ever used a TAMS set of equipment knows is that it takes more than a moment to set up, and anything that can improve the simplicity of transanal surgery, I think, is very much to be applauded. And I think one of the great advantages of the Visimax is clearly that it's so usable in almost any platform. It doesn't require a large amount of training or expertise or anything of that nature. It is can be applied to any system that you want to do it. Now, one of the things to remind people in the last few minutes that we have, if you have questions, please put them, into the system, onto the Q&A system, where we can answer the questions that we have coming through. But we already have a couple of questions through, and one of the ones that's come up very early was, and I'll throw this out to either of you, Mark or Matt. We'll start with you, Mark. Do you think there is any reason to think that we should be using different equipment or different filters or different setup for patients who are COVID positive versus patients that are COVID negative, or should we just treat everybody the same? What do you think, Mark?
Yeah, and that's a good question. I think that has to do with your level of index of suspicion and risk tolerance. I think that what we have done here at Advent Health in Central Florida is we've taken the very conservative and safe approach. We don't know. I mean, we test everyone. It's universal testing across the board. However, what we did very early on in this pandemic was the administration was incredibly supportive of this. We universally test, we universally mask, and we just assume everyone is COVID positive, even in the setting of a negative test. Because as Matt mentioned, and I mentioned earlier, even if you're COVID negative, if you had COVID, you will still potentially be shedding virus within the feces. And there's a theory, even though our patients universally get tested pre-op, and then they must quarantine until surgery, there's always a theory, there's always a possibility that they go to a COVID party, for example, and then come in COVID negative, but they just got it. They call it like an hour or two or 6 days or whatever it is before. And so to circle back to the question, I think that at this stage of the game, since there are so many unknowns when it comes to COVID transmission within the viral aerosolization, in my operating room, and I think within pretty much all of us in the Central Florida division here at Advent Health, we're taking the conservative route. We are treating everyone as if they're COVID positive, same equipment, same filters. Everything is tuned to filtering out, preventing and blocking and reducing the transmission as much as it possibly can of COVID-19. So we're sticking with the safe route on this one.
And I'm guessing, Matt, you'd probably support that, of universal precautions, assuming that everyone is COVID. It just makes matters easier. Would you agree?
Yeah, I think you always have to keep your guard up. And the one thing here, I don't know, but I know and feel, and looking around the world and watching people doing webinars in the UK about the safe return to surgery, that I think since April that we've been aggressive as far as returning to surgery, taking care of people at a pretty full pace. And What I do know is that we've been able to continue this without any breaks, getting a little bit better all the time, better systematics. And I couldn't be more amazed with the ability to return to my job and work and taking care of people while at the same time facing everything that we did. And so in the meantime, I think you have to, and I don't want that to get ruined specifically. I think in the meantime, you always, I'm a reasonable person about this. It's hard to get so crazy and then decide you're going to go to the supermarket, and that there's always going to be some exposure and risk. But I think in the operating room with patients, we keep our guard up. We do simple things that enable us, I think, probably good yield, and they keep everyone feeling comfortable, and they keep the patients going on.
Yeah, and just in case anybody's confused, just for the record, we don't have COVID parties in Advent Health. We've been thinking about it, but not for the moment. Another question, Matt, in terms of the ergonomics of the instrumentation. One of the big challenges with the insufflating systems, Air Seal, for example, is that the trocar and tubing is quite heavy. We discovered that early on with the when doing TAMI, it tends to drag on the port either upwards or downwards. Have you found any difference in the ability to maneuver the instruments if you use the Visimax system? Is it lighter, or is it just as complicated?
Yeah, no. There's no question that's a huge component. It's not only the tubing and everything else, but we know that we designed the trocars for the gel cap very specifically, so they were low profile, because any reduction of room inside that cap takes up space to operate. And so when you use any accessory trocars that are in past there, that they occupy a lot of extra room. And so on the other hand, this sits freely on the side, much like the ISB. It's just connected by the single or two tubings, and it becomes very out of the way and cumbersome. But that is a good question, because there's no doubt some of the accessory equipment, it causes some challenge actually making the surgery as ergonomically good as it could.
And we have another question that I'm going to also ask you, Matt, although I think I know the answer already, but which is, can you use the Visimax with the Air Seal system? If you're currently using would you recommend using it for TAMIS so that you get evacuation rather than just the trilumen Air Seal mode? Are you using them together?
Yeah, I do, and I will. And like I said, I would never show you this without showing you a surgery and demonstrating to you that I do this. I'm bananas about the visualization from the camera there to, again, the wall tension there, that if there's not adequate wall tension, you just can't perform this as perfectly as you'd like. And so I'll do whatever it takes. And if that means using an Air Seal and in conjunction with using anything else, as you can see with that case, I did use the striker insufflator in conjunction with this. And that's the real nice thing. It can be used to augment any insufflator. None of them are perfect. I don't always have access to an Air Seal, so I may say, great, I'm using that. You can see that I use the ISB routinely if I need to. But I am as interested in making this surgery always as good as it can be, not just for me, but for anyone else doing it.
And Mark, I want to turn to you just in the last moment that we have. We've been talking about transanal surgery a lot, but one of the challenges with robotic surgery, and particularly deep in the pelvis, with the close-up vision, has always been smoke extraction. Yep. Do you see that there's an advantage to a system like this, based on there's enough equipment in the room with the robot as it is now? Do you think this is going to have a potential to help without an additional expense of an expensive insufflator system, where you're simply looking for smoke extraction?
Yeah, I think that's a good question. I think the reality is, with deep pelvic surgery, tons of plumes of smoke will accumulate, and you're maybe 1, 2, 3 centimeters away from the tissue plane of dissection. I'm an avid user of these closed circuits of Air Seal and whatever else, because I do have that constant suction and filtration and smoke evacuation. But The reality is that deep in the pelvis, nothing is going to help well enough other than an actual suction device sitting right next to the camera. So for my robot crew out there that's doing a lot of these deep pelvic dissections that have issues with smoke and visualization deep into the pelvis, the big tip and trick that I can give you is have your assistant have 2 ports, use all the smoke evacuation tech you've got. Your assistant with one hand is pulling the rectum up. Your assistant with the second hand has a sucker right there, suctioning the plumes of smoke as they're forming. So you have smoke evacuation from the insulator device, whether it's AirSeal, whether it's Visimax. But in addition to that, you have an active suction irrigator, suctioning the plumes of smoke as it's accumulating right before your eyes. And I find that that's by far the best thing to have helped me maintain visualization deep in the pelvis.
Well, thank you, Mark. And we want to be respectful of people's time. And we've had a great conversation here tonight. First of all, I want to thank again Eleanor and the team at Boehringer Labs for supporting this meeting, this webinar tonight, number one. Number two, I want to thank Mark and Matt for 2 excellent presentations. It's always good to listen to people who really know what they're talking about, and I think you can see that's the case here tonight. Thirdly, I want to thank Matthias and his team, who nobody sees them, thankfully, because they're behind the cameras and they do all this work and they make it possible. And finally, just to remind you to watch the Twitter sphere for the latest updates on when our next webinar from Advent Health Colorectal Surgery will be. So with that said, thank you for joining us. Welcome wherever you were in the world, and we hope to see you again before too long. Good night.